Prosthetic joint infection risk factors. Preoperative risk factors. Various preoperative factors increase the risk of prosthetic joint infection. These include active infections such as local cutaneous, subcutaneous, deep tissue, or joint infections, as well as systemic septicemia. A history of previous local surgeries or infections also contributes to the risk. Post-operative risk factors. Post-operative risk factors include immune suppression, whether due to immunosuppressant drugs or conditions like corticosteroid use. Drugs such as anti-TNF agents, for example infliximab, etanercept, adalimumab, certolizumab, golimumab, and antimetabolites, for example leflunomide, are particularly risky. Poorly controlled diabetes mellitus, HbA1c greater than 7, chronic renal disease, acute liver failure, and malnutrition, for example albumin less than 3.5, total serum leukocytes less than 800, can further predispose to infection. Immunosuppressive conditions such as dysplasia, neoplasia, and HIV, with CD4 counts less than 400, increase the vulnerability as well. Additionally, inflammatory arthropathy, for example rheumatoid arthritis, psoriasis, ankylosing spondylitis, can be a contributing factor. Lifestyle factors. Lifestyle factors including morbid obesity, smoking, excessive alcohol consumption, intravenous drug use, and poor oral hygiene also play a significant role in increasing the likelihood of infection. Prosthetic joint infection pathophysiology. The most common bacterial organisms responsible for prosthetic joint infections include Staphylococcus aureus, Staphylococcus epidermidis, and coagulase-negative Staphylococcus species, particularly in chronic infections. Candida species, such as Candida albicans, are the most common fungal pathogens involved in these infections. Prosthetic joint infection classification. Time of onset. Infections can be classified based on their time of onset. Acute infections occur within 3 to 6 weeks of surgery and are typically confined to the joint space without invasion into the prosthetic bone interface. Chronic infections develop more than 3 to 6 weeks after surgery and are characterized by the formation of a biofilm by bacteria on the implant, which makes eradication challenging. The biofilm is composed of 15% cells and 85% polysaccharide layer, which helps bacteria adhere to the prosthesis and protect them from the host immune system. Source of infection. Infections can arise through direct invasion, such as from a sinus tract into the joint capsule or wound dehiscence. Hematogenous infections can also occur, where an infection from another part of the body, for example dental work, infected gallbladder, spreads to a previously infection-free joint. Prosthetic joint infection presentation. Patients may have a history of recent or active bacteremia, multiple local surgeries, or skin or epithelial tissue penetration, for example intravenous drug use, colonoscopy, dental work, ulceration, or wound complications. Symptoms of PJI. Common symptoms include persistent pain and stiffness at the site of the arthroplasty, which is present in over 90% of infected patients. Acute infections often present with swelling, tenderness, and drainage, while chronic infections show more subtle symptoms, with pain worsening over time and function deteriorating. Physical examination. On inspection, a sinus tract to the joint is a definitive sign of infection. Other signs include warmth, redness, and swelling, along with a low-grade fever. Motion is often limited by pain and swelling. Imaging in PJI. Radiographs. Radiographs can reveal periosteal reactions, scattered patches of osteolysis, generalized bone resorption without implant wear, transcortical sinus tracts, and implant loosening. Bone scan. A technetium-99m bone scan detects inflammation, while indium-111 scans detect leukocytes. A triple scan can differentiate infection from fracture or bone remodeling. While bone scans have 99% sensitivity, their specificity is lower, ranging between 30% and 40%. Positron emission tomography. PET scans may help identify areas of high metabolic activity using fluorinated glucose. These scans offer 98% sensitivity and 98% specificity. MSIS criteria. The Musculoskeletal Infection Society, MSIS, provides criteria for diagnosing prosthetic joint infections. Major criteria include the presence of a sinus tract communicating with the prosthesis or isolation of a pathogen from two separate tissue samples from the affected joint. Minor criteria, including elevated ESR, CRP, synovial WBC, and PMN levels, as well as purulence in the affected joint, are considered if at least 4 of 6 are present. Studies in PJI. Blood panels, including WBC count, are not highly specific or sensitive for prosthetic joint infections. However, inflammatory markers like CRP and ESR can be useful. CRP peaks 2 to 3 days after surgery and returns to normal after 3 weeks, while ESR peaks 5 to 7 days after surgery and normalizes within 3 months. Joint aspiration. Joint aspiration is indicated when infection is strongly suspected. The analysis includes cell count and differential, gram stain, and cultures. Elevated synovial WBC and PMN levels are suggestive of infection. Perioperative analysis. Microbiological tests and histology help confirm the diagnosis. Repeat aspirations or intraoperative specimens are used to identify the same organism. In equivocal cases, intraoperative frozen sections can help confirm infection. Treatment of prosthetic joint infection. Non-operative treatment. Chronic suppressive antibiotic therapy may be used in patients unfit for surgery or those who refuse it. This approach aims to manage symptoms and prevent the systemic spread of infection, although the success rate for eradication is only 10% to 25%. Operative treatment. Several surgical options exist, depending on the severity and timing of the infection. These include polyethylene exchange with component retention for acute infections, one-stage replacement arthroplasty, two-stage replacement arthroplasty, which is considered the gold standard for infections more than 4 weeks after surgery, resection arthroplasty, arthrodesis, and amputation for severe cases. Each method varies in terms of indications, techniques, outcomes, and success rates. Prosthetic joint infection case discussion. A 60-year-old male patient with a history of hip replacement 4 weeks ago presents with sudden onset of pain, swelling, and redness around the surgical site. He reports mild fever, and the wound appears to be draining. Laboratory findings show elevated CRP and ESR. Possible VIVA questions. What is the likely diagnosis in this case? The answer is acute prosthetic joint infection. The sudden onset of symptoms, pain, swelling, fever, and drainage, and the timing, for weeks post-surgery, suggest an acute infection. How would you diagnose this condition? The answer is, diagnosis is confirmed by joint aspiration, where synovial fluid analysis for elevated white blood cell, WBC, count and polymorphonuclear cells, PMNs, will help. Microbiological cultures of the fluid will identify the causative pathogen. Aspiration is critical to confirm the infection and identify the pathogen. What are the common pathogens for prosthetic joint infections? The answer is Staphylococcus aureus, Staphylococcus epidermidis, and coagulase-negative staphylococci. These are the most common pathogens associated with PJI, especially in the early stages. Prosthetic joint infection case discussion. A 50-year-old female patient presents 6 months after knee replacement surgery with persistent pain and gradual swelling around the joint. She has a history of rheumatoid arthritis and has been on methotrexate therapy. A radiograph shows implant loosening, and joint aspiration reveals a high WBC count with a positive culture for Staphylococcus epidermidis. Possible VIVA questions. What is the most likely cause of this patient's symptoms? The answer is chronic prosthetic joint infection due to biofilm formation. The infection has been present for months, and the pathogen is likely forming a biofilm on the prosthesis, which leads to persistent symptoms and difficulty in treatment. What is the significance of biofilm in prosthetic joint infections? The answer is, biofilm protects bacteria from the host immune response and makes eradication difficult. It also reduces the effectiveness of antibiotics. Biofilm formation is a key factor in chronic infection, making it harder to treat with antibiotics alone. What would be the management strategy for this patient? The answer is, two-stage revision arthroplasty is the gold standard for treating chronic infections. This approach allows for the removal of the infected prosthesis, followed by a period of antibiotic therapy and then reimplantation. Prosthetic joint infection case discussion. A 70-year-old diabetic male presents with hip pain 8 weeks after total hip replacement. He has poorly controlled diabetes, HbA1c greater than 8. On examination, the joint is swollen, warm, and tender. Laboratory findings show elevated CRP, ESR, and WBC count. Radiographs show early signs of loosening. Possible VIVA questions. How does diabetes mellitus contribute to the risk of prosthetic joint infection? The answer is, poorly controlled diabetes leads to immune dysfunction, impaired wound healing, and increased susceptibility to infections. High blood glucose levels impair neutrophil function and reduce the ability to fight off infections, increasing the risk of PJI. What is the role of CRP and ESR in the diagnosis? The answer is, CRP and ESR are inflammatory markers that are often elevated in PJI, helping to support the diagnosis when combined with clinical findings. Both markers are nonspecific but are commonly used to track the inflammation associated with infection. What surgical approach would you recommend in this case? The answer is, one-stage revision arthroplasty could be considered for patients who are not suitable for two-stage procedures. Given the chronicity of the infection, 8 weeks post-surgery, and the patient's medical condition, a one-stage revision may be appropriate. Prosthetic joint infection case discussion. A 45-year-old male with a history of knee replacement presents with knee pain and swelling 10 weeks after dental extraction. He recently had dental work and was not given prophylactic antibiotics. He now presents with signs of infection around the knee joint, with elevated CRP and ESR. Possible VIVA questions. What is the likely source of the infection in this case? The answer is, hematogenous spread from dental work. Dental procedures can introduce bacteria into the bloodstream, which can seed the prosthetic joint, causing infection. How would you confirm the diagnosis? The answer is, joint aspiration and microbiological cultures of the fluid are necessary to confirm the diagnosis and identify the pathogen. Aspiration provides direct evidence of infection by isolating the pathogen from the joint fluid. What preventive measure could have been taken before dental work? The answer is, prophylactic antibiotics prior to dental procedures to reduce the risk of hematogenous spread. Patients with prosthetic joints are at higher risk of infection from bacteremia caused by dental procedures. Prosthetic joint infection case discussion. A 55-year-old female with a history of renal transplant and immunosuppressive therapy presents with knee pain and swelling 5 weeks after knee arthroplasty. She is on immunosuppressive drugs, including anti-TNF agents. Joint aspiration reveals a high WBC count, and cultures grows Staphylococcus aureus. Possible VIVA questions. How does immunosuppression increase the risk of prosthetic joint infection? The answer is, immunosuppressive medications, such as anti-TNF agents, reduce the body's ability to mount an effective immune response, increasing susceptibility to infections. These drugs inhibit the body's inflammatory response, making it harder to fight infections. What is the first-line treatment for this patient's infection? The answer is, the first-line treatment would involve surgical debridement and appropriate antibiotics based on the culture results. In this case, Staphylococcus aureus may require extended antibiotic therapy. Surgical intervention to remove infected tissue and a tailored antibiotic regimen are necessary for treating PJI in immunocompromised patients. What would be the long-term management strategy for this patient? The answer is, long-term suppressive antibiotic therapy may be needed for immunocompromised patients who cannot undergo complete surgical revision. Immunocompromised patients may have difficulty clearing infections, and chronic antibiotic therapy helps control the infection while avoiding surgery if possible.